Hello, good morning. This is Dr. Li-Shei Lin. I am a reproductive endocrinologist at Reproductive Partners San Diego, RPSD, and I'm also on faculty at UC San Diego for the Division of Reproductive Medicine and Infertility. Welcome. Today the topic is going to be Fertility 101. So it'll be hopefully covering everything that you have in question. And feel free to fire a question to save it toward the end and to the Q&A session. And we'll talk about it, we'll discuss it. Okay, so I'd like to present two patients with two different situations. All of that, you see Mary, who is 42, who always get regular periods in her life, and she's been trying to conceive for past 3 months. If you look at the right side, this is Rachel, who came in at age 25, always have a regular period, sometimes don't get any period at all for 6 months. And she's been trying to get pregnant for about 4 years. For these two patients, both have a fertility issue. And I'm going to go on to discuss the reason and why do we look at them differently and how the urgency will be. Okay, so if you Google or read the old textbook, the definition of infertility usually is written as someone who had tried for 12 months or 12 cycles, 12 menstrual cycles without contraception and is not getting pregnant. Okay. The incidence of this in the developed countries nowadays is actually creeping up to 1 in 6 couples, which is pretty significant. So almost everyone, when you ask around, you will have friends or relatives who have trouble getting pregnant in some degree. Very, very common to see. So the question comes is, when should a patient look for help? Okay, so there are things that we put at a priority. The most important issue here is to look at the age of the women. Okay, so we'll say age, most important. After age 35, you don't want to wait for 12 months. You don't want to wait for 1 whole year. As long as you try without protection for 3 to 6 months, it's time to look for an answer. And most important, after age 40, now do not wait at all. Keep going, looking for an answer, asking for help. Now, this is the picture I'd like to show. So on the long axis is the number of the eggs, and the horizontal axis is the age of the woman. Okay. As you know, we women are very, very special in the way that we are born with all the eggs we have. Throughout our life, we do not make any new eggs at all. And that meant the sperms are made freshly every day until they turn about 65. So men and women are very, very different. So when you look at this graph, you see that as we get to the more mature age, the number of the eggs are coming down very quickly. So at puberty, it happens around 15 or so, and the prime time to get pregnant by our biological programming appear to be somewhere between probably 18 or 19 till 30. This is the best time, the optimal time, or the time of life that has the best success rate in getting pregnant. After 30, you see the decline, the slope of decline in the number of eggs becomes more steep. Then it seems to come to a stop at age 40. After 40, then here it labeled very cruelly as saying end of fertility. But at our age now, with the technology we have, we wanted to extend this a little bit more, okay, maybe till 45. But briefly, you want to look at this graph and say the optimal fertility. Am I here, or am I at a window of declining fertility? How much should I watch? Okay, is this the time for me to look for help? Or when I reach 40, what am I supposed to do? What else can I do? So we look at in general, what are the causes of fertility issues? About 1/3 will be a female issue. The other third is actually a male issue, especially from the recent publications from WHO, the World Health Organization. We are seeing more and more sperm issues. And the explanation is not very clear, but maybe it's from our environmental factor. Maybe it's from the pollution. Maybe it's from the chemicals that we have in our water, in our air, and in our food. So this is something that we have to watch out for about the sperms. Then the last third will be either mixed with both female and male factor, or the couple actually has got everything to get pregnant, but it's not happening. So we call them unexplained infertility, which is very frustrating, especially for a young couple who have normal tests on everything, but it's just not happening, even if they already timed their sex in the right window at the right time. So let's talk about how to get pregnant here. Okay, so here's a woman's system. Here's the vagina, the cervix, which is like the gate into the uterus. Okay, then coming out from the uterus on both sides are the fallopian tubes. Okay, these fallopian tubes actually got little fingers. Okay, so they hug on to the ovary. Okay, in a woman who ovulate, meaning that she gets regular period, her egg will be mature once a month, and the egg will be released. Okay, here is showing you that she just ovulated. One little egg just pop out from the ovary. Okay, now the fallopian tube got the little fingers. They are going to come over just like the baseball player. They'll pick up the egg, ideally. Then this egg will be stored at the far end of the fallopian tube. There, comfortably, listen to music, waiting for the sperms to come. And they'll stay there for about 12 to 24 hours only. It's a very short duration of time. If the sperms do not arrive in that window of 12 to 24 hours, then the egg will die. Then we'll miss the opportunity. Okay, so where does the sperm come out from? Okay, when a couple have sex, the sperms are ejaculated in the vagina. Okay, no matter how long one stays on the bed, how many pillows you put on the bottom, when you get up, 99.9% of the sperms will fall out. And that's how we human beings are programmed to do. And that is why when you look at the sperm count, it's counted in millions and millions. It's an incredible number. It's a big army we anticipate. So the few sperms that stays in there, they find their way into the door of the cervix. Then they cross this big ocean of the uterus. Then they have to swim for another 500 miles to reach the egg at the far end. When they reach the egg, they also cannot be just like gentlemen or tourists knocking on the door, watching and admiring the egg from the distance. They have to actually be soldier-like. invade, enter the egg, fertilize the egg. So therefore, the egg is fertilized at the far end of the fallopian tube. Now this fertilized egg, for some mechanism that it inherited, it will be slowly developing, dividing, and move back into the cavity of the uterus to implant. The journey takes about 5 days to happen. Okay, so after that, the embryo now will flow in a cavity of the uterus to find a good spot, and most of the time they will imprint here at the upper part of the uterus. Then they're growing root, just like the little flower seed growing root into the soil, the cavity of the uterus, holding on to the membrane. And it takes 1 more week for you to find out your pregnancy test is positive, you miss a period. That's how it happens. Okay, all right. So therefore, a fertile window, usually we say, okay, is about 5 days before you ovulate and about 1 day after you ovulate. Okay, so if you have a good chance to pick up ovulation by ovulation predictor kit, then you will see a surge from the pituitary gland. It will surge before the day you ovulate. So you will want to start to try 5 days before if you could. And fortunately, very fortunately, the sperm usually will survive for 36 to 48 hours. And some super sperm can make it for 5 days. And that is why you will want to do 5 days before the ovulation and 1 day after. That will cover your window of fertility. And you will want to have sex at least every other day if you could. Okay. So what happened when you come to a physician to ask for fertility help? Okay, the workup that we will be looking at will be the following. Okay, one is to look at the ovary. What's happening to the ovary? Are you ovulating? Okay, is the egg maturing and coming out? Another way we look at it is how are the fallopian tubes? How's the uterus? Are they friendly? Are they receptive? Do they want to hold on to the baby? Do they want to have the implantation happen? Okay. The other one is peritoneal factor, meaning that outside of the uterus, in the abdomen, the lower part of the abdomen, how is the environment? Are they friendly? Do they have obstacles in the way for the pregnancy to happen? Then the last but not the least is the male factor. Important part of this is male factor. So first thing you might want to do is to have your partner check the sperms if you want. Actually, if you want to do it very easy, just look at the sperm and how many sperms, how active they are, and how are the shapes of the sperm. It'll answer a lot of questions already. Okay, so let's look at how to assess the ovary, right? Okay, so the first question we would ask is whether you get regular periods or not. Okay. A person with regular period most of the time indicates that there is ovulation because the regularity of menstrual cycle is controlled by our brain, and our brain actually releases messages to stimulate the ovary to make the egg mature. When the egg gets mature in the ovary, it will send back a message to our brain and say, "Hey, I'm ready. I want to go. I want to do it." Then the brain will give it a surge, a push, which is the LH surge that you will detect on an ovulation predictor kit. Okay, so it will happen naturally, and you time it with your window or you time it with your ovulation predictor kit. Okay. However, if the menstrual period is not regular, then this means that ovulation may be off. Maybe there's no ovulation at all. So we actually these days have very, very good medication, very easy to treat. So don't be afraid. Very treatable. Okay. Then the next thing we look at, which is a little tougher to assess if the level is not high. So we just talk about, say, we are born with all the eggs we have, and the question will be, how many more eggs do I have in my ovary, right? Because we do not make any new eggs at all throughout our life. So there's a way to test that, okay? Quite a few tests that we can do to look at it. The first one to look at is AMH. It's a hormone made by the cells surrounding the egg in the ovary, and therefore, the more eggs there are, the higher the number will be AMH. And usually we use one as a cutoff. Okay. The other one is to look at how many eggs, how many follicles we can see by ultrasound. So these are called antral follicle, meaning the little eggs, the little follicles. An egg is not visible on ultrasound, but as it's growing up, it will secrete enough fluid around it such that it will make a follicle, which is practically a little water balloon that has the egg in there. Okay, so we can count these little ones. That number represents how many eggs are behind them. Okay, so you will find out that your physician will be doing an ultrasound for you to count how many eggs. Okay. The other blood test is an older one, which is to check on cycle day number 3, 2 hormones. One is FSH from the pituitary gland, and the other one is estradiol from the ovary. They are still useful, but most of the time, these top 2 numbers seems to be more precise, more accurate. So here I want to show a complicated picture to you about a menstrual cycle. And this is representing someone who has regular period, and wife do we know she ovulates, right? Okay, so the top row you will see these little guys, the little circles. These are the egg that are just waking up from hibernation. Okay, so they'll start to acquire some liquid and make a bubble in there. Okay, so we call them the developing follicles. And as they grow, by the signals from the brain, it will grow bigger and it will communicate with the brain. Eventually, it will mature up. Okay, so in the hormone testing, you will see that in the green box, you will see 2 hormones from the brain, the LH and FSH. LH goes to the ovary to stimulate the ovary to make hormones, while the FSH goes to the ovary to stimulate the egg, fertilize the egg to make it grow. Okay, so here you see the egg is mature, the follicle is mature. So it sends a signal to the brain and say, hey, I'm ready to go. So the brain will respond to it by a surge on the LH. Okay, this surge will actually be powerful enough to tell the ovary to go ahead release the egg. So now you see the big follicle mature, pop, the little egg is released. Okay, all right. Then what happened to the space after that? The space left over after the egg is released will form something we call corpus luteum. And this is a structure that will make progesterone. It'll turn yellow, it'll make progesterone to prime the lining. This part is the lining of the uterine cavity. It'll prepare for the implantation. Okay, so it'll make changes in such a way that about 1 week after the ovulation, it peaks here and is perfect and ready for the embryo to arrive to implant. Okay, all right. So the next thing we look at is how the uterus is and how the fallopian tubes are. Okay, so the fallopian tube is where the natural fertilization will take place. Remember, we say the sperm has to reach the egg in the far end of the fallopian tube, right? So if the fallopian tubes is blocked or is not functioning properly, then the sperm will lose the opportunity to meet the egg to do their work. Okay. And also on the uterus itself, are there obstacles in there, such as fibroids in the way? Okay, so and we'll look at other testing that we can do to find out. The classic way to do it is an X-ray procedure, which unfortunately is quite painful to do. It's called HST or hysterosalpingogram. What it does is we put fluid into the uterus and do an X-ray to follow that fluid to go through the fallopian tube. It is the current gold standard, but it's being replaced gradually by a procedure that is called setting sonor histogram or SIS. This one is done by normal setting going into the uterus and put some air bubble in there, and you will do ultrasound so that you avoid radiation there. And most patients seem to feel that this procedure is less painful and will achieve probably the result that we would like to see. Okay. Whether the answer is whether there's anything blocking implantation within the cavity of the uterus and whether the fallopian tubes are open. So here's the ugly picture to show you what fibroids are. Okay, you can see they can be coming in all sizes in all locations. And here's the original good-looking uterus. Now it's been distorted. Okay, a lot of time fibroids are not in the way. So this is just to show you that they can come in all sizes and all locations. Most of the time they are just muscle tumor of the uterus, and it's usually genetic, meaning that if I have fibroids in my uterus, most of the time I can find out either my mother or my grandmother or my aunt have fibroids too. So it's probably genetic. And most of the time it is non-cancer. So don't lose sleep on it. All right. Then we'll look at the other factor, which is in the pelvis, outside of the uterus. And this is where we talk about endometriosis, like lining of the uterus grow in the pelvis, and they get in the way for the uterus and the fallopian tubes to do their job. Okay, or someone who had infection in the pelvis, which causes scarring, adhesions that will prevent the fallopian tubes to do their work. So here's another ugly picture to show you that here we are looking down. Here's the uterus, and here you see these big areas. We call them endometrioma or chocolate cyst. This chocolate syrup-like fluid is really old blood, which is created by endometriosis, collected in the ovary itself. But a lot of times what they do is they actually do superficial or deep implantation in the pelvis, on the surface of the ovary, or on the surface of the uterus, in the back of the uterus, on the intestine, or on the fallopian tube, that's likely. And they can also cause problems for the fallopian tubes and the whole system to work properly. Okay, we'll skip this one. Okay, so next we'll be looking at the male factor, which is extremely important because as we say, 1/3 of the fertility is caused by a pure sperm issue. Okay, this is an old standard that was created by WHO, giving you the parameters. It's probably not most accurate up to this day, but it is still the best data that we have to show you. So these will be the numbers. But then these days, what we look at it very carefully is the morphology, the shape of the sperm. The shape of the sperm, if it is too off, then it may have to do with predicting whether the sperm is going to be able to fertilize the egg or not if they meet the egg. So that's one thing that we pay a lot of attention to. Of course, the number is critical too. We need to remember they are counted in millions. So they are truly a big army. And we would like to see a lot of them so that there are chances that the good sperms, the best sperms will stand out and have a chance to do their work. Okay, so other things we'll be looking at is the patient's medical history, any medical problem, what kind of medication she's on. And usually we would look at the medical history, look at the medication list to see whether there's anything that we do make changes, that anything that is not compatible, not safe for the baby during pregnancy, and we'll advise that. Okay, and lifestyle. Okay, very importantly, smoking. Okay, quit smoking, quit alcohol completely. Okay, we used to think marijuana may be safe, but in the past 5 years, there are really more and more data coming out to say that it actually affects the pregnancy, it affects the baby, and it affects the sperms as well. So if you can get off that, that'll be wonderful. Okay, and of course, stress. This is something that very difficult to be completely off. The modern day professionals, even almost everyone has stress. So if you have a way to relieve stress, that would be great. Okay, and looking at the nutrition part, there's a whole list of supplements we like. And it's easy to find if you Google it. Okay, and also try to control the weight to a good range. Okay, a good range. So we will say that there is probably more adverse effect on the pregnancy outcome or making it more difficult to get pregnant when the BMI is too much over. So watching the weight is something to put on the priority as well. All right, good. So what are the medications that we usually use, right? Okay, the easy ones will be oral ones like Clomid or Letrozole. Then the harder ones will be the injections, which is the brain hormone like FSH and LH, which we can talk about it in detail with your physician. And then for the male factor, a lot of times we will try to do insemination if it is just a little sleepy. But again, remember that the sperm has to have the capability to fertilize the egg in order to make insemination work. Okay, so if all that fail, then we always have in vitro fertilization, IVF to back up. Okay, so what are the indications? When should I move on to do IVF? Okay. Number one is if the fallopian tubes do not work well, okay, or severe endometriosis that are really in a way that make it impossible to get pregnant naturally, okay, then IVF can bypass them, okay. Also, if we only have a handful of sperms or weak sperms, okay, morphology issues, then doing IVF will bypass that because in the technique, in the process of IVF, we have a way to inject the sperm into the egg for you to resolve the gentleman sperm issue, I call it, okay? Then the third thing is we don't have a way to reverse. That is, we do not have a time machine to reverse age, and we also do not have a way to increase the egg count in a reserve. And this is something that one has to be vigilant about. Okay. Then next will be the unexplained fertility or not ovulating and have failed ovulation induction and other means. Also, there are issues about genetics, okay, in the family, or issues about chromosome problems. This is better to be resolved by doing IVF because when you do IVF, there's a way to check the genetic makeup of the embryo to avoid it. Okay. Then, of course, conditions. There are life situations that one will need donor eggs or surrogate to get pregnant. Okay, so let's talk about IVF. How do we do it? Okay, so IVF, the idea will be to stimulate the ovary to hopefully to be able to grow more eggs. And this is usually achieved by oral medication, injections, or combination of oral medication. Okay. So here you see that this is a woman's inside, the uterus, the ovaries, and you see the little bubbles now become bigger bubbles. The bigger bubbles meaning that the egg inside is maturing. So we have a way to do ultrasounds, blood tests to find out that they are mature by the medication. And that course, that ovulation induction injection period will be roughly about 10 days. Then when they look mature, then we can go in to harvest the eggs. Now remember, harvesting the egg most of the time is done under anesthesia. So you actually will be sleeping for the procedure. Here's a vaginal probe ultrasound that will guide us where the follicle is. There will be a very skinny needle going through the wall of the vagina, going inside to each follicle to aspirate, to harvest the egg. And there will be a team of embryologists nearby, and they will separate the egg and they'll take over after that. The whole procedure is usually about 30 minutes. There's IV sedation, we call it deep IV sedation, so you actually do not feel it, and it should not hurt during the procedure. So here's what the work that the embryologist will do after they take over your egg. So your partner will provide the sperm. From the sperm, they have a way to separate the better sperms. Okay, they'll pick up the best looking sperm, the most energetic sperm, and here's one egg. So a lot of times what they'll do is pick up one sperm and inject it into the egg to make it fertilize. Okay, so here are real pictures under the microscope. Okay, so you see a mature egg here. After injecting the sperm inside, the next day you are going to see two little circles inside the egg. One circle will be yours, your chromosome. The other circle will be your partner's chromosome from the sperm. So we know that this egg is fertilized. This then will initiate the egg to split. Now it becomes an early embryo. Okay, so day 2 and day 3. By day 3, you will see 8 to 12 cells in the embryo, in the early embryo. And all these cells, 8 to 12 cells, they look all the same. You cannot tell who's going to become the eyes, who's going to become the nose. Okay, so now we human beings, actually, remember we say implant happens on day 5. So this is what day 5 will look like. Okay, so usually we try to grow them to day 5. By day 5, you will see the embryo becomes 2 circles now. The smaller circle inside will make the baby, while the bigger circle outside will make the placenta. All right, this is the stage of the embryo that offers the option to do genetic testing on the embryo. And the way we do it is under the microscope. Remember, we say this is the baby, this is the placenta. So what we do is to go to the far end, stay away as far as possible from the little baby, take a few cells out from the placenta, extract the DNA, send it out to genetic company, that they will analyze the chromosomes or analyze specific mutation that you are looking for. Okay. In the meantime, keep the embryo frozen safely and sound. 2 weeks later, the genetic testing result will come back, and then we will know. Let's say, for example, if we have 4 embryos here, they will let us know how many are normal and how many are not normal. Most of the time, we'll then talk about when are you ready to transfer the embryo? Do you want to bank them a few years until you're ready to become parents? Or do you want to do it next month? Yeah, all doable. Depends on how your wish and how your life situation is. Now, how about for same gender couples, right? So we will need special considerations. Okay, the sperm source or the egg source, right? We need a lot of psychosocial support on this. So and in my experience, my patients who are same gender couples usually are very well thought out. They are very well prepared, and they are very good parents. Psychosocial support is very, very important. Okay, so you have options of donor sperm from anonymous donors of sperm bank, or you can choose to do non-donors. Or for donors eggs, you can again could be a non-donor, anonymous donor, fresh eggs, or frozen eggs from the egg bank. And of course, surrogacy. Okay, for male couples, this is very, very important to find a good surrogate. There are also agencies that would do that. Typically, the supply, the availability of surrogates are fewer, and therefore the wait time is usually longer. So once you create an embryo, you actually have the privilege, you have the liberty of keeping them frozen until you find a proper, a good surrogate to carry your baby for you. The next will be very, very important issue that is becoming more aware now. Now, for a single person, okay, for fertility preservation, okay, it is really something really good, in my opinion, that this allows the single woman to have the option to preserve their fertility without the pressure of fertilizing that egg, without the pressure of making embryos or becoming pregnant right now. Okay. So what this does is we are now getting better and better and very good at egg freezing. You go through this very similar process for the ovulation and egg retrieval. Then we harvest the eggs, then we freeze the egg. The good thing is that the soil survival rate is now reaching 80% in the country, and I think in the Reproductive Partners San Diego, we are averaging a survival rate of 85%, better than the national average. And this is something very, very doable, and there's no time limit. So something to think about. And we are seeing a trend of more and more younger women or more and more single women who take the advantage of doing egg freezing now, and it works out really well. The next one is for someone who has sperm source. Say, for example, a young couple who have sperms, but they are not ready to get pregnant yet. They are still in the process of their career or schooling. Then you can choose also fertility preservation by embryo banking, meaning that you can actually go through the IVF process, even go through the genetic testing process, and freeze the embryo, okay, for the duration that you desire. Okay, so if I say, well, I gotta get this project down, but I know that time is flying by, and I'm getting worried about my age, then this is a good time to do your embryo banking or egg freezing. Okay, then for the future family building, when you see time is right and situation is right. Okay, the survival rate of the freeze thaw for embryo national average is at 90%, and RPSD, I believe we are a little bit better than the 90%. So this is actually a very successful process to do. Okay, all right, and this is what I wanted to say about the fertility 101. Maybe a little complicated, but welcome to fire any question. Ready? Question? Okay. Let me see if can I make it bigger? So question is, what are the most common causes of infertility in women and men? Okay, very good question. The most common, I would say, these days for women is the ovarian reserve, the age, okay, followed by PCOS, polycystic ovarian syndrome, meaning not getting regular period, not ovulating well. Okay, and for the men, it'll be the sperm parameters that we see. Actually, a lot of time we don't have a good explanation of how come the sperms are sleepy, how come we are getting low morphology score, that they become gentleman sperms, and like soldiers that they can invade and fertilize the egg. Second question, okay. Does caffeine intake influence fertility? Okay, very good question. In animal study, unfortunately, when they do experiment, they feed the rat a lot of caffeine. So they can actually show that large quantity of caffeine will break up chromosomes, which is very frightening. Now, we human beings, of course, we don't take that much caffeine. There is a study a few years ago came out from Northern California, actually shows that for women who consume more than 5 cups of coffee seem to have a miscarriage issue. So this is really alarming because we think a lot of time miscarriage has to do with chromosome issues. Okay, so from that, we extended the implication to say that it's better to cut down your caffeine. If you can do it without, that would be great. If you cannot do it without, then bring it down and bring your coffee down. You can try decaf. Decaf is about 10% of the caffeine. But I know a lot of people don't like how the decaf tastes. But if you could just consciously bring it down if you could. But we don't really have a very clear data to say 1 or 2 cups will affect the fertility. Hopefully I answer your question. So what can I expect during consultation with me? Okay, very good question. Okay, so what would happen is when you come to me, I would ask you first, what is your perception and what would you like me to help you with? Okay, so then I will be aiming to the goal that you want to go, so that we can help to reach the goal that you want to reach. Okay, so for example, if you come to me, you say, well, I want to bank embryo. Okay, I'm not ready to get pregnant. My partner and I, however, we feel that we can make embryo now. So what I would do in general for all my patients, I will be doing a comprehensive ultrasound for you. We will do a 3D ultrasound to look at the anatomy of the uterus, and we will be looking at your ovaries, and that usually give us an intro follicle count. We can count the eggs and get some initial assessment of how the reserve is. Of course, after that, we will be doing the hormonal testing to put together the assessment of the ovarian reserve, and that will help me to decide how aggressive, how much time, where in the timeline do we stand, and then we'll take the option that will work the best for you. Okay, so basically the planning will be mutual discussion. I will be talking to you about what we'll be doing in the workup and what kind of treatment, the pros and cons of each options, and what will be the success rate for you. So next, you see in new patients? Yes, as you know, I just joined the group 3 months ago. So I welcome, of course, all the time see new patients. Just need to call the phone number here or the QR code. It's real easy to get, and I will be very happy and very honored, very thrilled to have you as a new patient. How long have you been a reproductive endocrinologist? A long time. Okay. I finished my subspecialty training in UCSD, the Reproductive Endocrinology and Fertility Fellowship at UCSD under Samuel Yan in 1994. I got board certified in OBGYN in 95. The next year, I got board certified in reproductive endocrinology and infertility. So counting all that, I should say I am in the field and practicing EI for almost 30 years. And ultrasound was already done to me. Do you recommend getting a second one, a second opinion? it depends on how your first ultrasound do. But here, when you come as a new patient, I usually would prefer to do your ultrasound myself, so it allows me to have a first-hand assessment. Not that I don't trust your first one, but it gives me a first-hand to get a feeling of how your uterus is and how your ovaries are. Okay, and there are also a few things that we are looking for, which may not be totally the same. In addition, your ultrasound actually is part of your new patient visit here. So it's all included in the service in your first new patient visit here. So they actually don't charge you extra. It is incorporated into your new patient visit. So I'll be very honored and very happy to do your second ultrasound, of course. Okay, my ultrasound shows that egg quality is low. Okay, I think they probably told you that the egg number is low. Is that right? Yeah, because ultrasound cannot really tell egg quality. Egg quality is actually a very difficult thing to do. It has to be done by actually take the eggs out, look under the microscope and see how they look like. Okay, and and but I think your physician might be mentioning that they didn't see many eggs. Okay, so sometimes there's a little bit of fluctuation in the cycle, in the menstrual cycle, depends on when this ultrasound is done. Okay, so if you get regular period, usually I prefer that we do your ultrasound before you ovulate in the cycle. So meaning that in the first 2 weeks of your menstrual cycle, like from day 1 to day 14, because you usually get a couple more eggs that way. After the ovulation, you will get a lower count on that. Okay, and but don't get too frustrated. The next ultrasound may be better. And what I would suggest you to do is to start to take some supplement. One of the best supplement that has good literature support, actually has scientific support, is done in Canada. They they actually show that if you take coenzyme Q10 or CoQ10, CoQ number 10, CoQ10, this is over the counter. Okay, they actually do different doses. So 600 milligram, 600 milligram is the high dose that we recommend. That they actually have data showing that you get better quality egg. Okay, so I would encourage you to start to take it. It's over the counter. Just go to the shop in any pharmacy and purchase that and take it in the daytime. It's a cell energizer. It feeds into the mitochondria in the egg to produce more energy for the egg and sperms. So because it's an energizer, so it actually energizes you from head to toe. A good idea is to take it during the daytime. Don't take it at bedtime, otherwise it may keep your brain too busy and you may have trouble falling asleep. So I would encourage you to take coenzyme Q10. A couple other things I also like. For example, a good antioxidant will be omega-3. Omega-3 comes from fish oil, or if you're a vegetarian, flaxseed oil is fine too. Take it at about 1,000 milligrams. It's a good antioxidant and it will protect your eggs and sperms from environmental pollution. Okay, and there are other good antioxidants from your food. For example, all the colorful berries, blueberries, raspberry, blackberry, strawberry, all the dark green leaves. Okay, so watch what you eat. A Mediterranean diet is what we like. Good quality fish, proteins, a lot of veggies, a lot of fruits. Okay, and of course, take away things that might be detrimental or cause damage to the egg, such as tobacco, cigarette smoking, such as marijuana, such as alcohol. Okay. Any more question? Looks like I answered all. Okay. Thank you for having me. It's my honor and pleasure to have you today.